Good evening.
Recording in progress.
Good evening, everyone. I am. It's a great privilege to have Sadashiv Vidu sir for this class. I'll request Dr. Tina Rajan. She is the YMO young leader who is in charge of Meet the Professor session to introduce sir with his CV and details. Dr. Tina, please. Uh,
Yes, sir. Very good evening to all those who joined. Good evening, sir. Good evening, Sadashivu, sir. So, it is my extreme pleasure and honor to introduce our speaker today, our very beloved and respectful Dr. Sadashivu, sir. He's a renowned teacher in the field of medical oncology. He is always known for his pleasant smile and his friendly attitude. And many of us will be lucky enough to have him as one of our dear examiners. So he is currently working as professor and head of the Department of Medical Oncology at Nizam's Hyderabad. And he's having more than 30 years of clinical experience and many publications to his credit, innumerable publications to his credit, and also written many chapters and books that are pertaining to lymphomas and leukemias. And he has been a principal investigator of many clinical trials and also co-investigator. So he has also received the Best Faculty Award in 2017 and Best Teacher Award from the state of Telangana. Over to
Yeah, thank, thank you very much, ma'am, for your wonderful introduction. Yeah, I think everybody knows me as a DNB examiner or DNB, you can say formative assessment examiner, or sometimes I'll also uh, yes, set the papers also. Okay, that we don't want to discuss that one, of course. As if once we are working in an academic institution, there's a responsibility to take care of some of the issues, especially correction of the papers, set of the papers, and these are the issues. But of course, I just thank you, Dr. Sujit. I think he asked me to just deliver this talk. I can't say talk; it's actually more of discussion. So our intention is here today is just 1 minute. Just 1 minute. Sorry, just some disturbances. Sorry, just someone is talking, and I think my presentation is visible. I think I would like to just give you the gist of the hemato-oncology. I think what I have experienced over this 15 to 16 years of my experience as a teacher, as an examiner, I think most of our students, I think they have some problem of hemato-oncology basics actually. Okay, and some of the centers really they are doing very good at hemato-oncology. And few of the centers, I think they have some problem in the learning as well as something the continuation of learning else. So during these examinations, I think we have found that I think we have to have the more classes of something hemato-oncology, which will cover this all the basics of our what you can say hemato-oncology. So we never treat any benign hematology, as you know, and at the same time, we don't want to leave the malignant hematology because if you see any of our centers, whether it's in Hyderabad, like in a Basavatarakam, MNJ Cancer Institute, or any other our institute, 80% of our caseload is hemato-oncology because we do more of hemato-oncology because the state run programs like we have the some Aragyashri, some other state insurance programs, they'll come to government hospitals and some trust hospitals for better treatment. And the most of our residents are very good at hemato-oncology. And some of the centers, they have the something parallel sessions of hematology as well as medical oncology. There, I think, and we have some lacunae in that one. I think to bridge those gaps, I think by Dr. Sujit has taken seniors, they have taken initiative to cover some of this hemato-oncology basics. I am going to give the some of the basics. I'm not going to give you any something like in trials, studies, and outcomes, and what the examiners they're expecting from a student. There's a main motto of my talk is today. It is exact, not exact talk. It's a discussion. So whenever you have any doubt, just post your doubts in the message chat box, or you can ask directly also. The during my examination, I think you know that one. I think one of my examiners are Dr. Sagar sir and Dr. Lalit Kumar sir. I think Mike. I think as you know, case presentation, something like an NMC DM courses. We have one long case and two short cases. But at DNB now we have the four cases. That's an equal importance of something like in a short and long cases. So what happened is, I think after presentation of my long case, I think one of the examiners asked me, "Oh, what are the investigations do you want to do?" I said all the related questions or related answers to the breast cancer. I have mentioned everything. Then what do you want to do? First, I started what other tests you want to do. I started enumerating something all your ERP or HER2, but later, what do you want to do? So for to before you start chemotherapy, I said I think we'll do the something organ reserve functions like complete blood picture, complete blood counts. You can CBC or CBP. Then I'll say RFT, LFT. So what do you want to do with the CBC? He asked. So we'll see some hemoglobin and everything. Anything relevant to your case, just tell me why you have mentioned the CBC. I think I could not get the answer, what I can say, exact what they're expecting from me. And suddenly, after some time, I realized, okay, what do you do? What do you want to do? Hemoglobin, you want to see, then WBC count, then do you see anything the WBC count? And suddenly we realized that when there is something like any infiltrative in blood, even breast cancer also, if it spreads to bone marrow, there is a leukoerythroblastic picture. So what type of questions they'll ask and what type of answer they'll expect from us different actually is a no, we can't even expect that type of question actually. So in an infiltrative disorder, so what type of picture you will see that one again they see leukoerythroblastic picture. What is the leuko? What is the erythroblast? Then I think the discussion went on to different context. So ultimately, what I want to say that one, never imagine that one you are going to get the questions only related to your case or your cases. The examiners they know how to assess a candidate in a holistic way, whether they have done any something like in a procedure, whether they have done something in a case records, whether they have done any research, they have done a publications. They'll ask many questions and they'll try to assess a resident or something exam going student in a holistic way. So in that way, just I wanted to give you some gist of this one. And I may not give all the answers, just I'll give the questions and some of the expectations from the examiners where you can easily answer those things. And broadly, I think hemato-oncology basics, I think you know that one. So there is whether you have a Hodgkin's lymphoma or non-Hodgkin's lymphoma, if you take something lymphoma. I'll go to why we have to discuss that one. Next one, leukemia, you know that one. Acute leukemia, chronic leukemia, ALL, AML. I don't want to go in depth of that one. And this is the one I think history, why it is important, especially in hematology or any case. And simply you can say that one age, I think age is again pediatric age group, the common disorders are different, adults are different, adolescents are different, elderly are different, age. And they'll simply, for example, a patient has come to you for there's something mediastinal mass of something around 9-year-old boy comes with a mediastinal mass. So we'll examine the patient and ultimately we'll say that what are different diagnoses. We'll say because 9-year-old boy, the commonest diagnosis T lymphoblastic lymphoma, T lymphoblastic leukemia. We'll say that one. Then simply they'll change the scenario to if the same symptomatology with SVC obstruction is something around a 22-year-old boy or 20-year-old something the male. So what are your different diagnosis? Again, they'll ask. Suddenly they'll change the scenario. So at the time again we'll think of again a lymphoma in another possibility, but germ cell tumors are more common than the something lymphoma. Then again, they'll just change the scenario. Okay, same patient, same symptomatology. With a 50-year-old male comes to you, what is your different diagnosis? So one, two, three. So simply they'll change the scenario because sometimes the examiner think that you know the something like in a diagnosis, but they'll change the scenario to test your knowledge. Don't feel bad because of these things are expected ones. Okay, and ultimately you mentally prepared to answer all those questions. Never go within a preoccupied idea of I'll get this case. They may ask the questions related to all that case. Never expect that type of something like an expectations. So next thing you know, gender and duration of symptoms also. Number of times they'll ask duration of symptom, whether it's a 2 months history, 3 months history, or 6 months history, either waxing and waning, something, any symptoms are there. Because lymphomas are, especially low grade lymphoma, partial lymphoma, or CLL, chronic lymphocytic leukemia, or something small lymphocytic lymphoma, there are waxing and waning symptoms are there. So with that, I think they'll say that when the duration of symptoms and the progression, the rapid progression, slow progression, or incidence progression. So based on the symptoms only, they'll assess that whether we can able to may not pinpoint diagnosis, but at least we could say this is a more probable.
Recording stopped.
1, 2, 3. Okay. So with that intention, they'll ask many questions related to the history itself. Next, I think you know that was the associated symptoms. Okay. These associated symptoms, I think, as you know, any lymphoma, there will be symptoms now. And any symptom related to any bone marrow compromise, as you know, anemia related symptoms, thrombocytopenia related symptoms, WBC count is low or infiltrated something. The WBC count may be normal, but may not have the functional WBC may not be that sufficient. So there you may have the patient may have the symptoms of something like a fever or infection. So again, everything is related to the history. Again, we have to correlate age, we have to correlate duration of symptom, we have to correlate and progression of the symptoms. Ultimately, you have to come to a conclusion at the end of your history taking. They'll ask us, what is your most probable diagnosis at this point of time? They'll expect us to give at least 1, 2, 3 different diagnoses. And again, they'll ask us, so why you have to say this? First one is your something like you said DLBCL. Why are you thinking the DLBCL or in a non-Hodgkin's lymphoma? Simply non-Hodgkin's lymphoma, simply can say that when the non-Hodgkin's lymphoma, most of the lymph nodes appear at the same time. But if you take the Hodgkin's lymphoma, typically they start with some one area, like in a cervical lymphadenopathy. Then it goes to contiguous lymph node involvement with a more prolonged history, something more than 6 months. Some patients might have received the tuberculosis treatment also because outside they diagnosed as a granulomatous inflammation. So granulomatous doesn't mean that again it's a tuberculosis. So based on the symptoms, I think the examiners will expect us to give 1, 2, and 3 differential diagnoses. But nothing wrong in that. I think the only thing is we have to substantiate our answer by saying some of the features like this. That because of this
Recording
age,
in progress.
because this age, this is the commonest lymphoma we can see. That this age, the commonest leukemia we'll see this pediatric age ALL is very common. Elderly AML is common. In that way, I think we can correlate 1.1, 1.1, and ultimately we can conclude by saying this is the my most probable diagnosis, sir, but I want to confirm by examining the patient. Again, you can say that nobody will just ask you many questions at this point of time, but mentally prepare to pinpoint at least one, either lymphoma or leukemia. In the lymphoma, whether it's non-Hodgkin's lymphoma or something like Hodgkin's lymphoma. Because Hodgkin's lymphoma, they have symptoms of their own. Very simple, I think, something huge lymphadenopathy, duration of 6 months. I think you can remember, assess that one. So non-Hodgkin's lymphoma, you know that one. Again, non-Hodgkin's lymphoma, the low-grade lymphoma or high-grade lymphomas. Of course, the symptoms are related diagnosis, but nobody can diagnose only on the based on the symptoms. But again, ultimately, pathologist will give the diagnosis. But before that, examiners will expect us to utter one diagnosis. Okay, so we know the diagnosis, but still, I think you have to substantiate your diagnosis by saying one, two, three. These are the my positive findings. Based on these, I think I am saying it could be a non-Hodgkin's lymphoma. Based on this, I am saying it's a Hodgkin's lymphoma. In the history itself, just remember that most of the examiners they'll ask you your differential diagnosis at the end of your history presentation, not at the end of your examination. So remember that. Next one is again, once you go to the examination, I think there are two, 3 points most important. Most of us will try to forget that one, especially. Try to mention your performance status first. I did not mention the slide, but you have to mention the performance status is most important in our lymphoma because most of the risk stratifications are based on our performance status. Because we tend to forget in the examination tension or something, but try to remember that the performance status. Again, they may ask you what a pediatric performance status, what type of the performance status, WHO, any other term is there. So they may ask you because based on your confidence levels, based on your timing, and they may ask you some of the questions related to this one. And ultimately, you have to start from examination from oral cavity to the something like in all the lymph node groups. But specifically, they'll ask you two areas. I made it in red. There's epitrochlear nodes and testis. If once you palpate this epitrochlear nodes, means it is a non-Hodgkin's lymphoma. There, so you can easily say that one because these are the lymph nodes very rarely involved in Hodgkin's. Okay, so remember that. So epitrochlear, papillary nodes, these are the lymph nodes specifically, especially for epitrochlear, are commonly involved in non-Hodgkin's lymphoma. And any male patient, just don't forget to examine the testis because some of the examiners are very particular about this testis examination. If you miss that one, I think they will not tolerate also. So any lymphoma, try to examine these areas. And ultimately, at the end of examination, again they'll ask you, so what is your different diagnosis? Whether you have changed your 1, 2 to 1 or 1 is there, still is remaining 1, 2, 3. So these are the ways I think you can think of that one. Just what I mentioned is next they'll ask you. So once you said 1, 2, 3 different diagnoses, they'll ask you how do you approach. So how do you confirm your clinical diagnosis now? So as you know that one, I think simply always never do one mistake. Most of times, what is, for example, patient presenting with us lymphadenopathy, what you say simply with the lymph node biopsy will say that one immediately. So don't do that. So kindly please just do say that one, I want to do the complete hemogram. So once you say the complete hemogram means, I think the hemogram, they'll see hemoglobin, WBC count, and platelet count, everything at the same time, some abnormal cells. So, especially, for example, in ALL, acute lymphoblastic leukemia, sometimes the lymphadenopathy also may be there. Once you do the CBP, you can just avoid the lymph node biopsy. So, in the examination, first thing you have to say that one, I wanted to complete hemogram with hemoglobin, WBC, platelets, and peripheral smear examination is most important thing. Why it is important? Okay. So you know that when the hemoglobin, the any bone marrow compromise, we may see the low
मैं
hemoglobin.
नहीं पोस्टेड यहाँ पे सिस्टर डॉक्टर रविंद्रनाथ है मैं तो आज के लिए देखने आप उनका ही नाम है
Sahit, Sahitya, please mute your mic. Okay. Microphone. Okay, some the hemoglobin. I think as you know, hemoglobin is definitely the bone marrow count will go down. Coming to the RBC, really do we get any information by examining the RBC, by seeing that RBC? Either hypochromic or microcytic, you know that one. Next one is if you see any Role formation, okay? If you see any Role formation in the peripheral smear, you can easily say that it could be multiple myeloma. So simply based on your simple complete hemogram, how many diseases you can diagnose? Simply they'll say one. They may ask you that type of questions. So definitely there's a once you see the Role formation, definitely it could be something plasma cell disorder, especially it is something multiple myeloma. You can confidently say that. So as you know, WBC total count number, you know. So differential coming to the differential count, I think most of the exams are found to ask, especially for example, either CLL, CML. I think in my examination also, one of my examiner asked me to write the differential count in CML. So you can imagine they'll give you the pen and paper. So you have to be very careful by writing that CML differential count. I think yet again they'll see that one whether you have made 100 cells you have counted or not. In the sense, what is the myelocyte peak? They'll expect us to write something myelocyte count will be more than any other WBC count. Myelocyte peak or bulge. At the same time, again, you have to see all the precursors, myelocytes, monomyelocytes, band forms, and basophils, eosinophils, everything they like see that. So very simple question, but very difficult to give at that point of time. But you should know. So coming to the platelets, I think these are the things I think the peripheral examination is most important. So by a proper complete hemogram testing will give us many clues towards our clinical diagnosis or to the or final diagnosis. So whenever you see something in a hemogram, don't just accept the something computer generated reports. Nowadays, most of the people they have the school terms, they'll use something one paper, but they never see the peripheral smear. So kindly see that they have seen the report the smears properly or not, because we may miss them. They'll see some abnormal cells. So what type of abnormal cells we don't know. So try to be very clear. So again, if you have any doubt, just repeat the hemogram with your expert pathologist. Ask them to review this one. I think once you have that one again, just I wanted to give you the people. They'll say, okay, you have seen some abnormal cells in the periphery. So what do you want to do next? I think we'll say cytochemistry. The cytochemistry, you can say that one. I think the myeloperoxidase for again AMLs. And again, one more you can see clear acid phosphatase. You can see clearly there's a one way of something the polarities, right? The polar is a TALL, T lymphoblast. The acid phosphatase will positive here. So don't worry about that one, because nowadays most of the hospitals they are not doing this cytochemistry because it's a waste of time and resources. But as a student, I think we should know how to just approach a case of abnormal some peripheral smear. We have seen some abnormal cells in the peripheral smear. So what do you want to do next? I think you can say that when we will do something cytochemistry. So you see that whether myeloblast or lymphoblast or simple precursors. Again, simple some questions they'll ask again. Okay, the WBC count is around 45,000. So how do you differentiate between a leukemia reaction and a leukemia? So simple again, they'll say something lab scoring. I think you know some of the score system, and they'll just try to assess us in a holistic way. What I'm trying to say, holistic way. So whether you know something about this or not. So once you answer confidently, they'll go to the next question. Okay. So in that way, I think the next question, most of the examiners are very fond of asking the how did we have seen something? One, they'll give you some one slide. Okay, they'll project on the something like nowadays we don't have any microscopes in the department. Simply now in the laptop or in the projection, we project into one slide. You have to start with it's a photo micrograph of something like the peripheral blood or BMA. So they'll ask whether is a peripheral blood smear or bone marrow aspect smear. I think as you know, I think these are the basic, we'll think that these are basic questions, but examiner think that they'll expect us to give them a clear-cut answer between these two. As you know, just I'll go through some simple the aspirate. Aspirate, you can see the bone marrow aspirate. Now clearly you can see so many cells are there, so many precursors are there, and with erythroblast, I think so you can say reticulocytes count may be very high, and you can see something like platelet aggregates and fat vacuoles you can see here. So any fat vacuoles, if you see in the something like an peripheral smear, that is confidently you can say that one it is a bone marrow aspirate. So I am just examining this. This is a photo micrograph of bone marrow aspiration. Start. Then they'll expect us to read those are the some of the cells. Next question, same aspiration slide. They'll see. So what are these cells? They'll ask us to explain. So without a hematological or hematology peripheral smear slide or bone marrow slide, the DNB medical oncology examination will not be completed. Okay, so be careful about this. Don't just listen to some of the pure colleagues or some of them. Just try to describe the cell. I think I have seen number of times. Sometimes of other people they may say this could be this one, this could be this one. Never listen to the your colleagues. They have appeared the examination one day before. They may tell you that one they have kept something like APML cell or something this cell, but don't end it, just carry on those things. I think because examiners they have to change every day. We'll change the slides and we'll change some of the scenarios, and don't expect, don't answer those things actually. Okay, try to describe why I'm saying this one. We have seen this type of answers long ago but not now. So try to be very careful. This once you see these are some thrombocyte aggregates, megakaryocytes. These are the typically you can see only in bone marrow aspiration. Okay, so peripheral smear you simply can see only you can see some of the cells which are abnormal cells, but you may not see fat vacuoles or something like that. So if you have something in a dry tap, for example, you could not aspirate much, so they'll do the biopsy. These are known as something like imprints, the bone marrow imprints. Sometimes they may ask you, so you had done the bone marrow, but bone marrow you did not get the sufficient something like aspiration. So what do you want to next? You can say simply thing I'll do something the imprints of this bone marrow biopsy. Then I'll examine that this is a bone marrow trypan biopsy. You can say simply these are all the bone acidification. You can see this one. So even though you may not diagnose the disease, at least you start explaining that one, this photomicrograph of a peripheral, photomicrograph of bone marrow aspiration, or photomicrograph of the trypan biopsy. I'm saying this one. Then they'll ask you to, then they may project in a closure view and they'll ask us what type of cell it is. Okay, but don't worry about the based on this only one answer. Your examination result will not be just fail or pass only based on one slide. Okay, but don't carry on some of you don't know something. We can say that like I am unable to recognize, I am unable to just what you can say find out this one. You can say simply and go. Once you say I am unable, then they'll go to the next question. Don't stuck there because we receive a clear cut instruction. Most of the times we receive instructions from the DNB or NMC by saying if any candidate is not answering that question, if he's not, so go to the next question immediately. They'll give the guidelines also. So don't stuck there. Say that one I am unable to recollect, I am unable to recognize this cell. And if you say that immediately they'll go to the next question. You may answer that question. Okay. So in that way, I think you can communicate in a better way and to start describe the cells. Okay, once I think they have done something like and what we can say you have seen some of the abnormal cells in the periphery. Maybe the WBC count, maybe 40,000, maybe 50,000, maybe 60,000. So what do you want to do next? Nowadays, I think everybody we are doing something. This is a phenotyping. This is a flow cytometry. Some people they may not go in depth of because we are not that experts in that particular field, but they'll try to assess if they want to give you something in a gold medal or distinction to you. So they may ask you some of the these some of the in-depth questions, and they better to just you can see the one imaging here. This is a typical of immunophenotype image you can see here. This is a flow cytometry, something a missionary. Okay, and they are doing that one. Ultimately, now we are very good at collecting the sample, maybe the ETF bottle, heparin, and we can go for the what I can say flow cytometry. But in the future, for example, if the pathologists are very confident they can do this, I think most of us now they were doing, we don't have any lymph node to aspirate, but some ascitic fluid or pool fluid is there or CSF is there. We can collect the fluid and you can send it for again flow cytometry. We are able to get the diagnosis with that also now. Either reactive lymph nodes or reactive lymphocytes or malignant lymphocytes. So one they'll see the clone. So once it a clone means that the clonality is established, it could be malignant. So in that way, I think we are able to do the some of the best. We use the best some of the best techniques to get the proper diagnosis. So these are the things I think are available, and you can say that when if the I am just, starting with something the peripheral smear examination has in abnormal cells. If you don't have that anything, something closer to me immediately, you can say that one we'll do some cytochemistry to differentiate between a myeloblast or lymphoblast. Then again, I can do something that I am unable to get the sufficient something number of cells in the periphery. Then you have to go for bone marrow aspiration, bone marrow biopsy. But most of the ALLs, then we may not do the biopsy because once you get the sufficient aspirate, no need to go for the biopsy. If you have something in a dry tap, unable to get the sufficient quantity of this aspirate, then you can do the biopsy. So here is again now, you can just flow starts from peripheral smear, cytochemistry, bone marrow examination. After bone marrow, again, they have to go for this immunophenotyping. So once you know this immunophenotyping, these are the some of the markers. You know, most of us, we know that one. What is the myeloid markers, lymphoid markers. And I think this is the one I think I don't want to repeat because you get everything very, very simple. But basically, we have divided into myeloid and lymphoid. Again, the lymphoid are B lymphoid or T lymphoid. In the myeloid, again, most of us will expect something like APL, like promyelocyte. That's the APL, non-APL. Because the entire diagnosis management different from other AMLs. So APL, non-APL. In that way, I think we have to differentiate basically by examining morphology, cytochemistry, phenotyping. These are the markers like an MPO. I think all of us we know that one. Be lymphoid, erythroid, or megakaryocyte. Ultimately, we'll get an idea what type of leukemia it is. Once you know that means what type of leukemia it is, the next step is again nowadays I think any lymphoma they are sending them for again with the molecular risk stratification, whether the high risk or low risk or intermediate risk or good risk or poor risk. So nowadays again they even you know that one nowadays NGS is the best modality to do this something all a marker test, but still our examiners will expect us from us at least give some what are the basics of cytogenetics. Why do you want to do the cytogenetics? Because they'll ask you what is the difference between a cytogenetics, fish, PCR, NGS. Okay, so what is the advantage of fish over the karyotyping? Again, they'll ask us what are the disadvantage of karyotyping. So what are the advantage of PCR? So simply can say that one I think is simple. I think you know better, but I think still I think we can say simply the numerical and structural abnormalities better analyzed by karyotyping. So numerically you can't get in any NGOs or fish. Okay, simply the structural and numerical abnormalities we can assess only by doing the karyotyping. So in that way, just prepare the answers for some of the just you think about yourself. What are the questions they make? But they'll ask you to even the theory also some of the times what we'll ask the differences between a conventional karyotyping and the fish or between fish and PCR because fish is again a different. I think you know the known abnormality we can say that a fish or PCR, a PCR versus NGS. So in that I think versus they'll give the versus as short notes. So better to prepare. These are the things I think why we have to do this one. The basically to risk stratify the patients. So based on risk stratification only, we can end a start treatment of them. So I think one we can see clearly here. If you can see some of these are the just I wanted to give a without discussing a Burkitt cell. You can see simply clear some cytoplasmic vacuoles are here. Okay. So any cytoplasmic vacuoles once you have seen here, definitely you can say it's a lymphoblast, especially there is a Burkitt cell, you can say. Okay. So once you see the Burkitt cell, again they'll ask you what are the regimens you want to use and what is the risk stratification, especially what is the staging system. Then they'll go to the something like directly they'll take you to the what is the drug which is most important in management of Burkitt's lymphoma. You will say again to methotrexate. Then they'll ask you what is dosage of methotrexate. So how do you they give the methotrexate? What is high dose methotrexate? What is low dose methotrexate? So what are precautions you have to take? Hydration, alkalization. Everything goes into that one again. Why do you want to give the 10% of methotrexate as a bolus, remaining 90% of the continuous infusion, where you don't want to give the 10% dose as a bolus? You can give something directly, like so for example, in CNS lymphoma, we don't give something bolus directly. We'll give high-dose methotrexate within 3 hours. So, and for example, osteosarcoma, I will give 12 grams per meter square. So then the discussion goes towards the, again, what you can say, your discussion goes towards again methotrexate. So be careful about this one. Is again just they may ask you anything about anything. Okay, don't think of just because you got this slide. So they may take you to towards again this methotrexate toxicity and go and rescue. How do you monitor everything? Okay, this is the per kit still. I think there's some. I think clearly the cytoplasmic vacuoles clearly are here. Okay, so whenever you see some clear cut the cytoplasmic vacuoles, you can see the bucket cell. Okay. Then I think you can say myeloid. Myeloid leukemia, we can say simply myeloblast or lymphoblast. Myeloblast one, you can clearly you can see here there is a something R rod. Okay. Some granules and R rods clearly visible. We can see in a myeloblast. So once you see this one, it is something like any granule or this R rod is a typical of myeloblast. So again, they may ask, what are those granules? What are those something rods? So you mentally prepare to answer those questions. But ultimately, our discussion again goes to the next one is this is the APL because these are curable malignancies, especially acute promyelocytic leukemia. You can see here is a clear cut all the something. These are the you can see clearly these are R rods. Okay, the bundles of R rods. You can see this one is known as faggots. So because these are the curable malignancies, they may ask you many questions related to this acute promyelocytic leukemia diagnosis. Most of the examiners that because of my 10, 15 years of experience, most of the examiners they'll ask you, okay, around Saturday evening in a EMD, one patient has come with the bleeding manifestations. So one of your resident they send the what you can say hemogram. Hemogram, the WBC count is only 500 or something else, something 5,000, but it looks like an acute promyelocytic leukemia. So how do you start your evaluating? How do you start your management? They'll ask you. So then you can start discussing that one. Okay, first one you can say that I'll send this again perforosmia. Perforosmia exam. I'll ask my pathologist to see the perforosmia whether the promyelocytes or not. Once the promyelocytes, I will concentrate more on again because patient has present with the bleeding manifestation. So I'll start doing that one again. I'll start platelet transfusion and cryopreserves, and you can start discussing that one because bleeding manifestations again. Some of the exams again they'll ask you because the patient represents the disseminated intravascular coagulation. Don't give the platelets first. So this is a sequence also most important. Don't give the platelets first. You have to give the something cryopreservatives first, then give the platelets because consumption coagulopathy. So these two minor things also sometimes they'll some examiners they may very particular about these issues. So try to be more very clear and crisp in your answering those questions. Most of the examiners, once they see this in APL, they'll ask you, how do you manage this case? So immediately they'll ask you whether you want to start therapy or are you going to wait for the confirmation of the report by seeing their fish or PCR because we'll get the PCR within 1 day because we are in-house. So most of the centers now they have something of PML or alpha testing in the in-house. We get the report within 1 day. But Friday or Saturday night, Sunday they may not work. So for that again you have to correct the coagulation abnormalities, and you can start the ultra. They'll again expect us to give the ultra and all-trans retinoic acid. I'll start at all-trans retinoic acid. So what a dosage, what mg per meter square? Why do you want to start that one? They'll ask, how does it act? So differentiating agent. So once you get the differentiating agent, so what are the complications of an ultra differentiation syndrome, pseudotumor, something cerebri? So some of the questions related again, it will go to something again ultra complications. How do you manage? How do you monitor them? Lipid abnormalities and something. Again, after confirmation of diagnosis, there's low risk, again high risk. Again, they'll have risk stratification. Now the WBC count is more than 10,000, we'll say high risk, and we can start directly some anthracycline based therapy, anthracycline and alternate retinoic acid. With a low risk, less than 10,000 WBC count, and you can simply can say that one I can go for either Atra and Ultra or the arsenal trioxide. Again, they'll ask you, why do you want to use the both the agents and the Ultra and retinoic acid, arsenal trioxide? So what are the differences between these two? Again, we have to mention that one because the extra weightage of the arsenal trioxide also has a apoptotic power, apoptotic ability along with the differentiating ability. So with that, I think you can say that one with the Ultron's retinoic acid has the only differentiating ability, but Ultron's retinoic acid has the apoptotic ability also. So we can without any anthracycle, because if you give the anthracycle, they may have some cardiac problems in the future. So with that intention, I'll try to just manage so that your questions again always going towards a different context, but without an APML discussion, most of the exams will not complete. Okay. So then again, just there are some of the APML. There are two hypergranular variant or microgranular. Microgranular variant, most of the times they may have the high WBC count. That means they may fall into high risk category. Again, some of the people now there's a BCR1, BCR2, BCR3 variant of PML alpha. So now the three variant is there, they are doing very poor. And we have some subset analysis. But at this point of time, you don't worry about that one. If they want to give you the gold medal, highest marks, they may ask you in many questions related to that one. You should be very careful about all these things, and ultimately these are some of the things. I think these are the cytochemistry, and they'll ask the fish. This is a technique, the fish technique. So you clearly can see here is again how do the green, this is red. The combination is something. It is very simple. So chronic myeloid leukemia, DCR-ABL, or PML, alpha, whatever it is. Ultimately, this is a combination. If it leads to something orange color. Okay. So with this is red, this is a green. This combination is a fish technique. So again they'll ask what are disadvantage of fish and what are advantage of fish. Very simple. Fish I think you can do immediately without any, but we can see only known abnormalities like in myeloma, what or BCR, ABL and chronic myeloid leukemia, PMLRF. But known abnormality will detect only by fish, and PCR also will try to find out only known abnormalities. And but NGS we have the this they can do whole exome sequencing and we can find many abnormalities. But again, to know the structural, for example, translocation between 15 and 17, we'll see, but APML, we will see that we can see only in karyotyping. Okay, so structural and numerical abnormalities we'll see only in conventional karyotyping. And if really if you're confident, if you're comfortable, like they may sometimes they may ask you how do they do the karyotyping also. So this is CML. I think this examination already mentioned in that one. The CML without the CML discussion, your examination will not be completed. Okay. So because this is that one disease, I think where we can see all sub that almost the lifespan of individuals are now it's equal to general population. I think with that, I think intention. So what is the CML risk stratification? They'll ask you what is the BCRA bill one, what is 190, P190, what is P210? Okay, how to differentiate between pH positive ALL versus a CML blast crisis, the lymphoid blast crisis. So these are some of the things I think about the P90, P190, P210, and how do you manage? For example, you have done something risk stratification. What risk stratification you are doing now? UTOS risk stratification. What is UTOS? What is ELTS? Okay, so durable long-term survival. What is the long ELTS? Why do they want to the scoring this one now? So we can say that when any risk stratification, we do it for only two purposes. One is to stratify the patients and to prognosticate. Second one is to tailor our therapy. For example, a low risk CML patient, and we can start simply with imatinib. There is no need to go for a second generation TKIs. And they will ask you again, okay, the patient can afford anything under the sun. So we want to use the imatinib, nilotinib, dasatinib, ponatinib, but recently asciminib also yesterday they got the approval for this asciminib upfront also. So which one do you want to use? So you have to be very careful, have to be very vigilant by giving those answers. None of the TKs show the overall survival benefit over the other. Okay, so you can say that one, but only thing is we have the good data on imatinib. So second generation TKs, even though you'll get the faster response, deeper response, but we may not use it continuous for lifelong. So what then again they'll say what is TFR? So what is the criteria to use the TFR? So what treatment free remission? What is treatment free remission? What are the studies? So everything going in something different direction, because wherever you have something the good outcome, they'll try to ask many questions related to the that disease. Okay, so because they wanted to test you something, because one of the highest curable malignancies, highest survival rates we have in the CML. So with that, I think they'll ask you again in the CML, do you want to do the bone marrow aspiration biopsy? Because you are going to get the diagnosis of the peripheral blood. Again, they will some of the examiners, they, for example, if the CMC people, they may not do the bone marrow biopsy, but aspiration biopsy. But in other centers, they may do that one, because they say that one, because we by doing the bone marrow, I'll get the something like a exact blast count or precursors number. I'll get the exact something like a best material for karyotyping and cytogenetics, where I can find the cytogenetic abnormalities or clonal abnormalities. Based on that, the AP or accelerated phase will be described. Third one is I can understand this fibrosis. So sometimes the fibrosis also will give us some idea. So the outcome also based on some of this fibrosis. So reticulin staining and everything. So that means by doing the bone marrow, you can say that one, I am going to get the exact number of the blast count. I'm going to get something like a good material for karyotyping to find out some abnormalities. Third one, I'll know the exact status of this reticulin fibrosis, because sometimes these patients may not respond. Even though they respond, they may not tolerate the exact dose of the correct dose of imatinib or dasatinib. So you can have to substantiate your answer by saying these are the examinations. Okay. So this AP, I think I don't want to go back. Again, they just now mentioned the blast crisis. So again, they'll ask you how do you differentiate the AL, lymphatic blast crisis? How do you manage that one? Blast phase? How do you manage the myeloid blast phase? How do you manage? So many people now they have the different protocols now. But ultimately, okay. So try to be very confident that one. I think all myeloid blast crisis will treat like a AML with the TKI, lymphedoplastic will treat like a lymphoid leukemia with the TKI. So which TKI is the best one now? People they are saying the ponatinib is the best one because it has the good efficacy, but of course only problem is toxicity. You should be very careful about that. Again, they'll ask you what is asciminib? Can we use the asciminib in this blast phase? No, the asciminib can be used only in chronic phase, not in accelerated phase or blast crisis. And again, they will ask you T315, what is T315, what are the drugs, assumed dosage. Regular dosage is only 80 mg, but T315 dosage is something like 400 mg. So what I am trying to say is just because they wanted to give us a idea. So how much do we know about these common diseases first? Okay, rare disease anybody can diagnose that one. So ultimately, this is a karyotyping. What this is CML? Just I wanted to give the examples of this one. But again, they'll ask you how do you monitor the response? For example, any leukemia, not the CML, any leukemia post induction. Why do you want to again bone marrow? What is the MRD? Okay, what is the cytogenetic response? What is molecular response? Everything again based on this your leukemia and type of what treatment what we are given. APML we may not do the bone marrow after injection. So because why do you want to do the bone marrow examination only after 4 months of or after completion of consolidation? Because everything has its own rationale. So with that, I think how to assess response means again you can see the bone marrow. We have to see the peripheral smear examination. Like in CML, we have to see the no precursors, normal WBC count. So it never based on the hemoglobin. Okay. So they ask you whether this hemoglobin is only now 6 or 7. So still the patient is in remission or not. So hemoglobin doesn't count under the something any response criteria. So some of the times they'll try to give you some of the clues, and some of the times they will confuse you also. But don't worry about that. Ultimately, you'll assess something like hematological remission, do the bone marrow, next molecular remission. We'll see some of the remissions, especially in a high risk. How do you do the manage, especially ALLs? But coming to the something like leukemia, CLL, I think I don't know. Once you see the peripheral smear, if you see some smudge cells, you'll say it's a CLL. There's something very clearly can see this one, some of the smudge cells, the CLE. Okay. The phenotyping, this, sorry, people may ask you how do you do the phenotyping. Then these are the things that is from a, especially ASCII time, they will give some of the 2 or 3 pictures like this, and they'll ask you to read this on CD45, the stem cell factor. Okay, CD19 again is it there or not? CD19 again is an ALL factor. So ultimately, these are the things I think you should remember that this phenotyping also they'll give some pictures and they'll ask you to provide the diagnosis. So with this, I think we can ultimately there's a simple like there's a leukemia. How do you approach clinical history, peripheral examination, bone marrow, cytochemistry, immunophenotyping, and then you can molecular profiling to know the risk stratification. Okay, simple lymphoma. I don't want to go in depth of that one again. Just I think because sufficient. We may have the different discussions, but here is again approach to lymphoma. Also, again, you have to start with again hemogram. Never forget that. For example, a patient of some generalized lymphadenopathy coming to you, a 60-year-old man, I think simply by doing the CBC, you can see CLL can be diagnosed by peripheral examination. They may not need a lymph node biopsy. So start with simple CBC or complete hemogram, then imaging, a lymph node biopsy or bone marrow can be done. Again, there are so many questions related to whether they have to, can we avoid bone marrow in certain lymphomas? So simply Hodgkin's lymphoma, there is no bone marrow involvement signs, so better you can avoid that one. Even certain scenarios, DLBC also, you can avoid the bone marrow examination. So the most of the times in a lymphoma case, these set of questions they will ask you. What is the role of hemogram? What is the role of imaging? Again, what of imaging also you will do that one. They'll ask whether you will go for PET CT or CT. And PET CT also, again, you should know this again, just I'll go to the next one. Again, what type of response? Questions related to again the Lugano criteria for diag staging and response assessment also. What is intended to score 1, 2, 3, 4, 5? If it 3 is there, what is this? Whether patient respond or not? If the 4 is there, patient respond or not? Because after 3 or 4 cycles, especially Hodgkin's lymphoma,